morning, everyone. Thank you for joining us today for Dr. Paul Hernandez webinar today. It's exercise, physical activity, and pulmonary rehabilitation and pulmonary fibrosis. Dr. Paul Hernandez is a respirologist and head/chief division of respirology at the Central Zone Nova Scotia Health Authority. He's the medical director of the Pulmonary Rehabilitation Program and co-lead of the 3 Immediate Care Unit at the QEII Health Sciences Centre. He's a professor of medicine in the Faculty of Medicine at Dalhousie University in Halifax, Nova Scotia, Canada. Dr. Hernandez is president-elect of the Executive Committee of Canadian Thoracic Society, past chair of the Adult Respirology Examination Board of the Royal College of Physicians and Surgeons of Canada, and past chair of CTS COPD Clinical Assembly. Prior to moving to Halifax, he completed medical school and postgraduate training in internal medicine and respirology at McGill University. His main clinical and research areas of interest are COPD, asthma, pulmonary rehabilitation, and pulmonary hypertension. Dr. Paul Hernandez.
Thank you, Sharon, for the introduction and for the opportunity to speak to your audience today. It's my pleasure to speak to you from the East Coast, here in the East Coast of Canada. We're in the middle of a hurricane, Hurricane Teddy, but fortunately it's been downgraded to a tropical storm this morning, and the lights and power are still on, so we hope it stays that way throughout the presentation. As you've mentioned, I'll be speaking about exercise, physical activity, and pulmonary rehab, and I look forward to comments and questions after the presentation. And if there's any burning questions during, then if you send those to Sharon, she may pass them along to me during the talk as well. If I can advance the slide. Letting me advance the slides. Okay, there we go. So I'll just mention at the outset that I do have a number of potential conflicts of interest due to some of the activities I do with companies, speaking and involvement in clinical trials. You can see the companies there that I've done work with, and some of those companies do have an interest in pulmonary fibrosis and have products that are either available or coming to market to help treat pulmonary fibrosis. So what is it that you should hope to gain from attending today's session? Well, I hope that you have a better understanding of a number of questions. And I'll say at the outset, I'm gearing my talk more towards patients and families, but I hope that if others are attending, healthcare professionals, they'll also benefit from attending. But in terms of patients, they should have a good understanding of why am I limited when I try to exert myself? Is it a good idea for me to try and increase my physical activity level? And how can I exercise in a safe and effective manner? So let's start with a discussion about pulmonary fibrosis itself, very briefly. Interstitial lung disease, as the name implies, involves injury and repair, which is abnormal, in the interstitium of the lung. The interstitium of the lung is, you can think of it like the supporting architecture, the framework of the lung. What gives the lung its structure and holds everything together. And we can find the lung interstitium dispersed in a number of areas in the lung, but it travels along the bronchovascular structures, so along airways and blood vessels, holding those together and giving them support. It does form a layer between the air spaces and the tiny blood vessels, the capillaries, at the alveolar level, at the level of the air sacs. And it's a very thin layer of supporting structure at that point. That's what you could see at the bottom picture of the alveolus, the air sac. And it also provides a structure along the outside of the lung, just below the pleura, and as well dives into the lung into something called interlobular septae, and it's in those areas where the lymphatics of the lung run. So the interstitium is fairly extensive throughout the lung, surrounding blood vessels, airways, air sacs, the pleural lining, and around lymphatics. And this part of the lung can be, it is a site of injury from lots of different causes. And it's that cycle of injury and abnormal repair that can lead to scarring or lung fibrosis. Now, the interstitial lung diseases, there are many different types of interstitial lung disease, and this is a classification system that's almost 20 years old now. It has been slightly modified and updated over the last 20 years, but largely this is the classification system that we still use today. And interstitial lung disease, we can think of it as a result of exposure to certain things in the environment. For instance, occupational exposures to things like asbestos can cause lung fibrosis. Environmental exposures may cause a reaction in the lung called hypersensitivity pneumonitis, which in its chronic form can go on to cause lung fibrosis. Many medications as well can injure the lung and result in lung fibrosis. We skip the second panel on idiopathic and move on to connective tissue disease. You can see that many of the common connective tissue diseases, such as scleroderma or rheumatoid arthritis, can be associated with lung injury to the interstitium and lung fibrosis. The next box, you can see sarcoidosis, which is a chronic inflammatory condition that can affect many organs in the body, but the lungs are among the most common targets, along with the skin and lymph nodes. And then there's quite a number of other rarer conditions that can result in injury to the interstitium of the lung. There is a large category, as you can see, the second box there, idiopathic interstitial pneumonia, where we can't identify a cause for the injury to the interstitium of the lung. And there are many different types of interstitial lung disease which are idiopathic in nature that you can see identified in the box at the bottom. One of the most common is something referred to as idiopathic pulmonary fibrosis, and about half of all the idiopathic interstitial pneumonias are in fact idiopathic pulmonary fibrosis. This is the most common of the relatively rare idiopathic pneumonias associated with injury and abnormal repair and lung scarring, which tends to be progressive over time. And for which, thankfully, over the last number of years, a number of treatment modalities have become available. Notably, there are now medications that are available and approved in Canada and elsewhere in the world that can slow disease progression. But today we're going to focus more on the non-pharmacological management of lung fibrosis. How do we go about assessing a patient that we are seeing with interstitial lung disease? Well, we assess them by taking a good history and doing a physical exam. On history, we look at the symptoms. Now, the typical symptoms of someone who suffers from interstitial lung disease or lung fibrosis include shortness of breath or dyspnea, exercise intolerance, cough, which is usually dry, but not always. Some patients do produce a fair bit of phlegm, and fatigue. It's important for us to look for causes for why someone might have lung fibrosis by taking a good occupational history, environmental exposure history, travel, smoking history, as smoking is a risk factor for many of the forms of interstitial lung disease, and exposure to other risk factors such as radiation and medications. We also take a thorough family history, as some of the forms of interstitial lung disease have a genetic or hereditary component to them. And this is actually quite common in Atlantic Canada, as we have large cohorts of families with pulmonary fibrosis and other forms of interstitial lung disease. And then we look for comorbidities such as connective tissue disease that might be associated with interstitial lung disease. On physical exam, importantly, when we listen to the lung, we hear a sound that's referred to as a crackle. And a crackle is a fairly intermittent sound. It sounds sometimes so fine that it sounds like ripping apart Velcro. And so you might often hear physicians say that they heard Velcro sounding crackles when they listened to the lungs with their stethoscope. We sometimes also hear a sound called a squawk, and a squawk is a sound that happens when the lungs become fibrosed, and that fibrosis stretches the small airways, the bronchioles. We have a sound that sounds somewhat like a crackle and somewhat like a wheeze, sort of a mixed sound that we hear during inspiration. And some patients with lung fibrosis will go on to have a change in the shape of their the end of their fingers in a form called clubbing, especially idiopathic pulmonary fibrosis, but other interstitial lung diseases such as asbestosis are also associated with clubbing. We're not exactly sure why clubbing occurs, but it can be an indication of lung fibrosis. There are other causes, though, that are associated with clubbing besides lung fibrosis. As a next step, after a good history and physical examination, patients will typically have breathing tests. And you can see in this slide flow volume loop from spirometry on the left and lung volumes graphically on the right. The characteristic of patients with interstitial lung disease is that their lung volumes are reduced, so they have small lung volumes, especially their vital capacity can be reduced. And because of the architectural destruction and distortion related to the lung fibrosis, not demonstrated here, other tests that look at how well the lungs exchange gas can be quite abnormal. So the diffusing capacity is often reduced along with the vital capacity as an indication of how well the lungs take gas into the lungs from the air that we're breathing. And this can be demonstrated as well through measurements of oxygen levels on physical examination or during testing, as we'll talk about shortly. Typically, patients will go on to have imaging of the chest in the form of chest x-ray and then ultimately CAT scan. And the CAT scan is often allows us to decide among that broad classification of interstitial lung disease, what type of interstitial lung disease a patient has. This is a CT scan, a CAT scan with fine cuts, very thin cuts of the lung, which demonstrates extensive fibrosis with reticulation, extra lines near the edge of the lung, and this honeycomb-like shapes, these cystic structures in the lung, which is the hallmark feature radiographically of lung fibrosis in a pattern called UIP, or usual interstitial pneumonia. And that lung fibrosis will often stretch open parts of the lung where the airways are, and we end up with something called traction bronchiectasis or bronchiolectasis. You can also see on this image that the edges of the lung and the bottoms of the lung tend to be more affected than the top or the central parts of the lung in a condition such as usual interstitial pneumonia or idiopathic pulmonary fibrosis. Well, what is the end result of these changes in the lung? Well, As I mentioned, symptomatically, one of the biggest challenges that patients face is that they are shorter breath, but particularly shorter breath when they try to exert themselves. So exercise limitation is a common early and late finding in patients suffering from pulmonary fibrosis. In fact, most patients with pulmonary fibrosis, if they're sitting quietly at rest, will not be short of breath. And it's only as they start to exert themselves that they notice that they are more breathless than they expect they should be. Anyone can get short of breath looking at this lovely picture of stairs in the park in Barcelona. And this certainly would face a challenge in terms of exercise limitation for patients suffering from pulmonary fibrosis to tackle these steps. Now, we have, on the good side, we have a tremendous amount of growth of understanding of how patients are affected by pulmonary fibrosis. And this is this fairly complicated slide tries to explain some of the reasons why patients feel short of breath in relation to pulmonary fibrosis. And as you can see, that all parts of the lung structure that are close to the interstitium can be affected. It can affect blood vessels. It can affect the function of airways. It can affect the air sacs or alveoli, and the ability of the airways, the air sacs and the vascular structures to work together to get oxygen into the body in terms of gas exchange. So a combination of factors that leads to increased dyspnea in patients suffering from pulmonary fibrosis. Similarly, the reasons for exercise limitation are multiple in patients with pulmonary fibrosis. We talked briefly about the mechanical or ventilatory limitation. Patients have low lung volumes, but not only are the lungs small, they're also, because they're fibrotic, quite stiff. And so the lung compliance is reduced, and it takes more effort or more work to take a deeper breath. So as patients try to exert themselves and need to breathe more, it's difficult to take a deeper breath. So patients tend to breathe more rapid and more shallow and expend more energy to take deeper breaths as they exert themselves. As I mentioned, the interaction between the air sacs and the blood vessels is disturbed by this fibrosis in the interstitium, and gas exchange can be affected. And even patients who have perfectly normal oxygen levels in the blood when they're sitting quietly at rest will often desaturate. Their oxygen level will drop with even modest levels of exertion. So oxygen desaturation with exercise is a very common feature for patients with pulmonary fibrosis. This interstitial inflammation and fibrosis particularly can disrupt blood vessels and decrease the amount of the pulmonary vascular bed, which can lead to an increase in pulmonary artery pressure and resistance against which the heart has to pump blood through the lungs. So pulmonary hypertension is a very common feature, which puts a strain on the right side of the heart. And then lastly, all of these effects of low oxygen saturation, poor cardiac function, as well as deconditioning and the effect of some of the medications patients may be exposed to, can have a negative effect on their peripheral muscle function, such as the muscles of their arms and legs. So patients with pulmonary fibrosis are limited in when they try to exert themselves because of effects that on the level of the lungs, the heart, and the muscles. As mentioned, the lung volumes are small, the lungs are stiff, and they're distorted by the fibrosis, which affects how well the lungs can get oxygen into the body. The heart, the right side of the heart in particular, which is the side of the heart that pumps blood through the lungs to pick up oxygen, is under significant strain because of the higher pressures and higher resistance to blood flow. And there are a number of factors that contribute to weakening and fatigue at the level of our peripheral muscles, and that is due to chronic inflammation, hypoxemia, poor nutrition, and as we will see in a second, inactivity can play an important role in muscle dysfunction in patients with lung fibrosis. So how do we go about assessing exercise tolerance in patients with interstitial lung disease? Well, as I mentioned, history is important, and patients will typically report their shorter breath, particularly as they exert themselves. They may also complain of exhaustion or fatigue, particularly of the exercising muscle, rather than complaining of shortness of breath. We objectively assess exercise tolerance with a number of different tests. We can do so-called field exercise tests. They're usually not done in a field, they're usually done in a hospital. And the two most common field exercise tests that we use are the 6-minute walk test, which is very commonly used in North America, or the shuttle walk test, which if any of you remember from elementary school, you probably called it the beep test, where you go back and forth and have to go around the course faster and faster as the beeps get shorter and shorter. That is a test that's more commonly used in Europe. We can also do exercise tests in the laboratory, typically in the same lab where you have your breathing test done, in a test called the cardiopulmonary exercise test. We'll talk about that in a second. And then as I mentioned, the peripheral muscles can be affected as well as the breathing muscles. And we have tests that can test the strength and endurance of those muscles that can be affected by lung fibrosis. Let's start with the 6-minute walk test. As the name implies, it takes 6 minutes to complete. As you can see in this picture, there's usually 2 cones that are placed 30 meters apart, and the patient is asked to walk around the loop, around the course, as quickly as they can, without any encouragement, for 6 minutes. And the main thing that we measure is how far an individual can walk, the total distance they can walk in 6 minutes. But then we also can assess how much breathing discomfort they experience using the scale on the right-hand side, the modified Borg scale, everything from nothing at all the way to a maximal amount of discomfort, as well as how much discomfort they experience in their legs. Oftentimes, patients will wear a pulse oximeter, which allows us to measure oxygen saturation and heart rate with a Bluetooth technology, so we can actually monitor that continuously during the test to see whether their oxygen level drops during exertion. And as I mentioned, oxygen desaturation with exercise is a very typical feature of patients with pulmonary fibrosis. Now, there have been lots of studies done over the years that have looked at the value of the 6-minute walk test in patients with pulmonary fibrosis. We know that patients can do this test reliably, repeatedly. So if you do it and then repeat the test, it has a very high reliability with an ICC of 0.83. This is a study that was done in over 800 patients with pulmonary fibrosis who had relatively mild to moderate degree of lung function impairment. You can see that the distance that they walked on the walk test in 6 minutes correlated to some degree with other measures of lung function, such as their vital capacity, which looks at the size of the lung, the breath that they can take, as well as the diffusing capacity, how well they can get gas into the body, and correlates to some degree with questionnaires that look at quality of life, the St. George's Respiratory Questionnaire, and measures of chronic dyspnea, the UCSD Shortness of Breath Questionnaire. But the correlation is significant, but relatively weak. What we do know from this study and other studies is that how far an individual can walk is a strong predictor of poor outcome. So individuals who can walk short distances have a higher risk of death from pulmonary fibrosis than individuals who have a well-maintained exercise capacity. And as well, individuals who, when you repeatedly test them over time, if their walking capacity is decreasing over time, that also correlates with poor outcome. So low exercise capacity and a drop in exercise capacity is a predictor of a poor outcome in patients with lung fibrosis. I mentioned also that oxygen often drops, oxygen saturation level drops during exercise, and this can be assessed during a walk test. One of the ways we can look at it is how much a patient's oxygen level drops during the course of the walk, and this also correlates with poor outcome in patients with pulmonary fibrosis. So a low baseline oxygen saturation before an individual even starts to walk, below 88%, is a poor prognostic feature. And then a drop of oxygen saturation during exercise is also indicative of poor outcome in patients with pulmonary fibrosis. So this simple, relatively easy to do, short test, the 6-minute walk test, does give us a lot of prognostic information for patients with pulmonary fibrosis. Lower exercise capacity, a drop in exercise capacity, low oxygen saturation, and a drop in oxygen saturation during exercise are all poor prognostic features. We might also use, instead of this simple field test, a more complicated test, a cardiopulmonary exercise test. I must admit this is much less commonly used to assess our patients with pulmonary fibrosis than the walking test or the field test, but is an important test that is available for us to do in the pulmonary function lab. You can see an individual there who's doing the test on a cycle ergometer or a bicycle, stationary bicycle. It can also be done on a treadmill. And during the time that the patient is cycling or walking on the treadmill, we can assess symptoms. We can assess their heart function. Patients will have a 12-lead electrocardiogram on that allows us to look at their heart rhythm tracing. Their blood pressure is measured continuously and their heart rate. We look at oxygen saturation. We look at how well a person is breathing in terms of how quickly and how deeply they are breathing. And we can look at how well the body is taking oxygen in and how well it is eliminating carbon dioxide. So there's lots of things that we can assess during a cardiopulmonary exercise test done in the pulmonary function laboratory. And just like with the 6-minute walk test, the results of a cardiopulmonary exercise test are helpful in predicting patients who are at higher risk for poor outcome. This is a study that Charlene Fell from Calgary did a number of years ago, showing that patients with low exercise capacity, and they use a measure called the VO2 max. You may have heard that term. So VO2 max, how much oxygen a person can get into the body. Low VO2 max is predictive of poor outcome in patients with pulmonary fibrosis. And even when you adjust the results of the exercise tests for other factors that predict poor outcomes, such as age, sex, smoking status, or baseline lung function, low exercise capacity still is predictive of outcomes such as mortality. I'm going to take this opportunity to take a drink of Sharon said to make sure I indicate for you that I'm drinking something very healthy here. It's a blueberry pomegranate sparkling water. It's early in the morning, and that could be a good time for you to take a drink of coffee while I take a short break. And now let's get back onto the presentation. So, physical activity. Let's talk about that. Obviously, if a patient has shortness of breath, and particularly if they're short of breath when they exert themselves, one of the things that individuals may choose to do is be less physically active. And physical activity is an important health outcome and a predictor of health outcomes in interstitial lung disease. How do we go about assessing how physically active an individual is? There is a yellow square box on your presentation. Can you remove it? I'm not sure. Sorry. Apologize if you see a yellow square box on the presentation. I'm not sure if I am able to remove it, but so how do we go about assessing physical activity in interstitial lung disease? We can do it by history and by questionnaires that try to assess how active an individual is. I can say that asking patients how active they are is fairly simple to do, but not very reliable when you compare it to objective measures of how active an individual really is. So we have a number of ways that we can assess, objectively assess physical activity. Many of you perhaps use these in your daily life. So pedometers allow us to count the number of steps an individual is taking. You can wear these. Many of your phones actually have them built right into the phone apps. Or you could use a more complicated device, an accelerometer, which not only counts the number of steps that you take, but also can give a marker of how often you are physically active, how long you're active for, and how intense the physical activity is. It also can tell you the opposite, how much time that you spend sedentary. And so increasing physical activity is good, as well as decreasing the amount of time that we spend sitting or lying in a sedentary fashion. Now, I'll remind you that we're going to talk shortly about exercise and how to improve exercise, but really you don't need complicated exercise equipment to increase your physical activity levels. As this ad campaign from Healthy Tomorrow Foundation indicates, the best piece of exercise equipment that you have is your own body, and physical activity is really about just moving your body, and any sort of movement is important and has health benefits. Obviously, the more you do it and the more intense it is, the greater the benefit. But any degree of physical activity can impart on you positive health outcomes. And this has been demonstrated in patients with pulmonary fibrosis. This is looking at step counts, and step counts do correlate with other markers of lung function, as well as exercise capacity. So the more active someone is, they tend to have better preserved lung function and walk further on the exercise tests. And importantly, if you look at panel D, the number of steps per day, where you're looking at time over months and survival probability on the y-axis, individuals who are more active and have greater step counts during the course of a day have a better survival than those individuals that are more sedentary and less physically active. So just like lung function and exercise capacity are predictive of prognosis in pulmonary fibrosis, physical activity is itself predictive of prognosis. And this again has been shown in other studies that increased physical activity over the course of time, and this is measured with an accelerometer, can lead to a better outcome. So there are a number of studies now that have demonstrated the importance of maintaining physical activity to improve individuals' survival. And I'll refer you to the Canadian Pulmonary Fibrosis Foundation website, cpff.ca, where there is some excellent information for patients on how to maintain physical activity and how to increase physical activity and exercise in your daily life. So that's a very useful website with lots of important information on how to live with pulmonary fibrosis, including some very useful information and videos on exercise and physical activity. One of the things that we mentioned earlier is that patients with pulmonary fibrosis will often desaturate during exertion. Their oxygen saturation will decrease. So one of the questions that you might ask, and has been asked in the literature, is would it be beneficial for an individual to wear oxygen when they're active, when they're moving around? So would it be helpful for you to carry an portable oxygen concentrator, or to drag behind you an oxygen tank? Will that help? Well, there have been a number of studies that have tried to look at this to some degree. Unfortunately, the data to this point has been fairly limited and fairly disappointing. What we do know is that use of supplemental oxygen can improve oxygen levels to a small extent while the person is exercising, but particularly in terms of recovery. So after someone stops exerting themselves, their oxygen level comes back up to normal quicker than someone who's not wearing oxygen. But it doesn't necessarily translate into a patient being able to walk further or being less short of breath. So wearing supplemental oxygen to this point has not been demonstrated to improve walking distance, physical activity levels, or symptoms such as shortness of breath or leg fatigue. So the jury is still out on the role of supplemental oxygen use in patients with lung fibrosis who don't have a low oxygen level when they're sitting quietly at rest. Now, patients who have low oxygen levels at rest, they may benefit from wearing oxygen. But if you only desaturate with exertion, right now I would say there is no good evidence that wearing oxygen will help you feel better, do more, or live longer. Let's finish up with talking about pulmonary rehabilitation. We've talked about the importance of physical activity and exercise as predictors of outcome. One of the best ways for an individual to improve their exercise capacity and learn how to exercise in a safe and effective manner is to take part in a formal pulmonary rehabilitation program. And you can see the definition here of pulmonary rehab. It's an evidence-based, multidisciplinary program. It's comprehensive intervention for patients with chronic respiratory diseases who are symptomatic and that their symptoms are negatively impacting on their daily activities and quality of life. And the goal of rehab is to increase patients' participation in their daily life, improve their symptoms, and ultimately may even have a benefit to the healthcare system and society at large. If you did get referred to a pulmonary rehab program, you can expect that your participation will have a number of components. You will be assessed at entry and at completion of the program. You will take part in an exercise training program, which will have both aerobic and muscle strengthening components. You will learn more about living with pulmonary fibrosis through self-management education. And this will not only teach you about pulmonary fibrosis, but also help you adhere to health-enhancing behaviors, such as increasing physical activity and exercise. And when you graduate from a pulmonary rehab program, you will be given a program that you can continue to do on your own after the completion of the program. Typically, the types of patients that go to pulmonary rehab program can have a variety of different types of chronic lung diseases, such as airway disease, COPD, and asthma, pulmonary hypertension, lung cancer, or before and after lung transplant. But certainly patients with interstitial lung disease are commonly involved in pulmonary rehab programs right across the country in Canada. And you can see that pulmonary rehab programs are available throughout the country, particularly in large population areas in Ontario, Quebec, Alberta, and BC. But there are rehab programs spread out across the country. Unfortunately, though, although the capacity on an annual basis of patients that can take part in pulmonary rehab has slowly been increasing over the last 20 years, still the capacity is extremely low. In 2015, when we last surveyed this, there were only about 10,000 spots per year for rehab programs in the country. Most pulmonary rehab programs are delivered on an outpatient basis, but attached to a hospital. But some of them are in community centers or through telehealth for more remote participation. And there are a small number of inpatient pulmonary rehab programs in the country. And this is what a typical pulmonary rehab program facility might look like. You can see a number there from across the country. The fairly fancy, beautiful setup they have at Hôpital Laval in Sainte-Foy in Quebec City, all the way down to the more modest setup at Montreal Chest Institute. But all of these facilities provide excellent exercise training opportunities and education for patients who participate in their programs. A number of different types of healthcare professionals are typically involved in delivering rehab programs, from respiratory therapists and dietitians, but importantly, and nurses, but especially physiotherapists or kinesiologists or exercise specialists that help guide the exercise training component of rehab programs. We'll skip those. In terms of the type of exercise that you will learn to do at rehab programs, typically patients learn both aerobic exercise training as well as muscle strengthening activities. And in terms of aerobic exercise training, we use the FIT principle, F-I-T-T. Patients typically will do 2 to 3 supervised exercise sessions a week at the facility, but also be given a home program that they will do on the days they're not at rehab. We exercise at relatively high intensity, so we measure how much you can do maximally and ask you to exercise at a relatively high workload. And a typical training session might be 5 to 10 minutes of warm-up, exercise from 30 to 45 minutes, and then a cool-down session. And patients will exercise either on walking tracks, treadmills, exercise bicycles, arm bicycles. So a variety of different modalities are used to do aerobic exercise training. Learning more about living with chronic lung disease is also an important part of pulmonary rehab, and you can see the typical types of education topics that are covered on a weekly basis during your participation in rehab programs. And this pulmonary rehab has been studied in patients with lung fibrosis. This is one study recently published in 2018. This was a 6-month outpatient rehab program. Patients attended rehab 3 times per week for the first 3 months, and then twice a week for the second 3 months. And this was compared to patients with pulmonary fibrosis who didn't take part in pulmonary rehab. And you can see that during the participation in rehab, patients improve both their aerobic training capacity in terms of how much they could do walking or cycling, as well as their muscle strength. Their strength improved in terms of, for instance, the chest press or leg press. So how much muscle strength they obtained during the course of their participation in the training program. And this translated into important improvements in exercise capacity. You can see the panel A, 6-minute walk distance. The closed circles are those patients who participated in rehab. The open circles are those who did not. You can see an improvement over time in walking distance on the walking test. Panel B, you can see the peripheral muscle strength improved in terms of leg strength. And this translated into an improvement in health-related quality of life, as well as physical activity level. In panel D, you can see the step count increased in patients who took part in rehab. And there have been a number of other studies that have looked at pulmonary rehab. I won't go through them all in detail here, but in this forest plot, you can see if the little diamonds are to the right of the vertical line, this favors pulmonary rehab. And for example, in patients with pulmonary fibrosis, when you look at improvement in 6-minute walk tests, this improves with pulmonary rehab. To the left here of the vertical line favors pulmonary rehab, and you can see that dyspnea is decreased, so an improvement in shortness of breath with pulmonary rehab. And quality of life, again, moving to the right of the vertical line indicates an improvement. Patients with pulmonary fibrosis improve with pulmonary rehab relative to those who did not participate. Just going to finish up by mentioning a very important clinical trial that's ongoing in Canada in 8 sites across BC, Alberta, Ontario, and Quebec that Chris Ryerson from Vancouver is leading. And it's trying to look at a number of the issues that we've talked about today, the role of oxygen and pulmonary rehab or exercise training in patients with pulmonary fibrosis. It's called the HOPE IPF study. These are all patients that are being recruited from across the country with pulmonary fibrosis who are on treatment with the antifibrotic nintedanib. And they will all take part in a pulmonary rehab program that will last 8 weeks. They'll attend 3 exercise sessions per week. And patients will be randomized to receive either high oxygen concentration, 60% oxygen, or lower oxygen amounts, just to maintain their saturation above 88%, but not above oxygen concentration above 40%. And this study will look at how this improves exercise tolerance, symptoms, physical activity levels, and quality of life. And I should mention that this study is being done at a number of sites in Canada from an unrestricted grant provided to the investigators by Boehringer Ingelheim. These are the inclusion and exclusion criteria for patients that will be enrolled in the study. As mentioned, they have pulmonary fibrosis with evidence of lung dysfunction and will be treated with nintedanib. So this will be an important study, and patients will be closely followed over the course of a number of weeks that they're involved, not only in the exercise training program for 8 weeks, but in the 4 weeks of follow-up post-exercise training to look at the impact of both exercise training, but also supplemental oxygen to improve a patient's exercise capacity and physical activity levels, and to see whether those changes translate into improvements in patient symptoms and quality of life. So an extremely important clinical trial. So I'm going to end here and look forward to your questions. We've discussed that exercise limitation is common in interstitial lung disease, such as pulmonary fibrosis, and it does relate to multiple factors that affect the lungs, but also the cardiovascular system and peripheral muscles. We've demonstrated that reduced physical activity levels and low exercise tolerance, particularly if associated with oxygen desaturation, are associated with poor outcomes in interstitial lung disease. And I hope you appreciate that exercise training is something that can be done safely and effectively in patients with interstitial lung disease, particularly if you have the opportunity to participate in a supervised exercise training program, such as a Pulmonary Rehabilitation Program, and that you saw that the Pulmonary Rehab is widely available across the country. And if you haven't been referred to a program by your physician, this is something that you might consider asking them to do. So I'm happy to stop there and take any questions that you have for us. So thank you.
Great. Thank you very much, Dr. Hernandez. I have several questions for you. The first one was, what is a recirculation on CT scans?
Recirculation.
That was an earlier slide that you had shown on the CT scan as a circular CT scan.
Oh, I'm not sure. I'm not entirely sure what the question is asking, but in the CT scan that we showed earlier, we did show a number of features that are commonly found in patients with pulmonary fibrosis. Those circular or cystic lesions are referred to as honeycombs, and they are the end stage of lung fibrosis. When the lung is damaged by fibrosis, it's left behind with a cystic structure, basically a hole in the lung with surrounding lung fibrosis. And we can actually see those cystic structures on the CAT scan. And we refer to that as honeycombing. And that really is a hallmark radiologic feature that is necessary for us to be sure that someone has this UIP pattern of usual interstitial pneumonia pattern on CAT scan that is common for certain types of pulmonary fibrosis.
Great, thank you. The next question is, given with COVID-19, how can you do rehab at home?
Yeah, I apologize for not covering that in my talk, so I'm glad the question has come up. That is a challenge. At the Canadian Thoracic Society, we have just produced a document that was not yet published, but will be soon available on the Canadian Thoracic Society website, which discusses how to deliver pulmonary rehab in the age of COVID. There are a number of different possibilities. Rehab programs have already started to offer virtual pulmonary rehab for patients at home, where they connect with patients through Zoom or other platforms to try and supervise their exercise activities at home. Also, it allows patients to participate in group or individual education sessions remotely without the necessity of coming into a facility. But also, as we get to currently relatively lower levels of community levels of COVID-19, rehab programs are slowly starting to reopen across the country. But they're doing so in a very cautious and careful manner with much greater attention to infection control measures that can protect patients who participate in rehab. So for instance, our own pulmonary rehab programs here in Halifax have slowly reopened over the summer at reduced capacity, increased physical distancing, patients and families who are coming wearing masks when they're not, and many of them even during exercise, for example. careful attention to cleaning of equipment after use, individuals using a single piece of equipment throughout the time that they're at the exercise class. So there are a number of things that rehab programs are doing to allow themselves to reopen, but also at the same time recognizing that the capacity is greatly reduced because of the infection control measures put in place. And so looking at ways to try and deliver rehab to patients virtually in their home. And so both of those strategies are being used to deliver rehab in the age of COVID. So thank you for that question. So I don't, even though we're in the midst of a pandemic, that shouldn't deter you from, as a patient, asking about referral to rehab, and it shouldn't deter you as a clinician from referring your patients to pulmonary rehab programs, because as I said, we're up and open again, and trying to provide rehab to our patients.
Great. Dr. Hernandez, several people have asked if you're able to share with us a website where they can look up where's the nearest virtual rehab that's online that they can then, log on to.
Yeah. If you go to the Canadian Thoracic Society or the Canadian Lung Association, both of those, you should be able to find that information. If it's not available, not easily findable, searchable through that, if you send a question to the Canadian Thoracic Society through their website, they will let you know where the nearest pulmonary rehab facility is to where you live. We do have a record of most of the pulmonary rehab programs in the country and the contact information. So we may not know yet at this stage which programs are open fully, delivering virtual. We've just started to try and collect that information now. We certainly know where all the rehab programs are and how to contact them, and we're in the process of collecting information on the plans for those programs as they reopen during the pandemic.
Okay, great.
I would send that question to the Canadian Thoracic Society. So if you type in CTS and lung into your web browser, you can find their website quite easily.
Okay, thank you. You had mentioned aerobic exercise at these rehabilitation centers. What about yoga?
Mm-hmm. Yoga and mindfulness and other physical activity and breathing exercise interventions haven't been as well studied in pulmonary fibrosis, have been studied in some other chronic lung diseases as means of allowing patients to have better control over their breathing and experience less dyspnea. Not as much of an evidence base in pulmonary fibrosis, but certainly no obvious reason why a patient with pulmonary fibrosis might not benefit from the increased physical activity and through the learning of techniques to have better control over their symptoms and awareness of their breathing that might come from yoga or other similar practices. Just not the evidence base isn't there from a literature point of view in IPF, but there certainly is in other chronic respiratory and other chronic conditions evidence of benefit.
Okay. And would Tai Chi and swimming fall into those categories as well?
I think Tai Chi certainly would fall into the similar category, and there may be an evidence base that I'm not aware of in pulmonary fibrosis. I haven't seen it, but swimming I would put in the category of other aerobic physical activities such as cycling or walking, if someone prefers swimming. Swimming obviously combines aerobic activity with resistance, So there is the additional benefit of resistance training, particularly for upper extremity, but less of the benefit related to the core muscle use related to gravity. So there are resistance and aerobic benefits to swimming, but so I would say yes, if that's an enjoyable aerobic and resistance modality that someone would like to participate in, they should enjoy similar benefits as they would with walking or cycling or other aerobic activities.
Okay. Dr. Hernandez, someone wanted to know, if you're diagnosed with pulmonary fibrosis or IPF, should you immediately start exercise regime?
Yeah, I think you should remain physically active, and physical activity versus an exercise regime, they are different. So you should try and make sure that you remain active in your daily life, that you're not spending all of your time sitting or lying, that you're finding opportunities to get up and move your body. Even standing is better than sitting, and walking is better than standing. So any sort of physical activity that you do will be beneficial. Whereas an exercise regime where you do a specific amount of physical activity at a set intensity for a period of time, especially if you're going to do it at a high intensity, in that case, it's probably best to discuss that with your physician and ensure that it's safe for you to do. The individuals may have comorbidities such as heart disease that might need some modifications in the way in which they exercise, or some other health conditions that might result in changes in an exercise prescription for that individual. But physical activity, simple physical activity, even walking on a daily basis and gradually increasing the amount that someone walks, aiming to try and walk 30 to 45 minutes daily at a minimum. That is something that someone could start building in right away without necessarily needing to go through much in the way of testing to ensure that it's a safe activity for them. Obviously, listening to your body. If you're experiencing chest discomfort, dizziness, or fainting spells, or excessive degrees of shortness of breath, then stop that activity and discuss that with your physician to see whether further testing, such as exercise tests, is necessary to identify why those symptoms are there. So that, I would say yes, increase your physical activity level. If you want to do higher intensity forms of exercise training, then that's best to speak to your physician before you embark upon a exercise training regime. And that's why something like Rehab is particularly helpful, because there you start out in a supervised manner and you know what exercise to do, how to do it safely, what intensity to do it at, how to monitor for symptoms that might be red flags that you should slow down or stop.
Okay. Another question is, how do you know if you are getting enough oxygen during exercise?
Yeah, that's a difficult, without actually measuring it with a device like a pulse oximeter. You may notice a change in your color of your skin, or someone else may notice it in you. You may become more bluish in coloration, especially in your nail beds, for example. But it may not be necessarily associated with excessive symptoms. So individuals can have an oxygen level drop without it necessarily significantly increasing the amount of shortness of breath they experience. So may not be able to rely solely on symptoms, may be able to notice it through a changing color of your skin or nail beds becoming more bluish. But really, to know if you desaturate, you'd need to have it measured with a device such as a pulse oximeter, which might measure someone's oxygen saturation at rest and with exertion. But as mentioned, if someone is not doesn't have low oxygen levels at rest, there isn't really any good evidence that giving oxygen just during the times that someone's exerting themselves leads to better outcomes. We will know more after the HOPE IPF study of giving high amounts of oxygen during a formal exercise training program, pulmonary rehab, results in better outcomes. But at this point, we wouldn't necessarily recommend using supplemental oxygen if the only time a person's oxygen level was low was during physical activity. But those are the ways you can assess it. What you would do with the information is a bigger challenge. There are some individuals who may have other health problems such as heart disease, and then a very low oxygen level, or pulmonary hypertension. A very low oxygen level in those individuals may put additional strain on their heart, and in those individuals we may want to give them supplemental oxygen to protect their heart from those low oxygen levels. But if without something like coexisting heart disease, for the most part, we would recommend against the use of supplemental oxygen for transient exercise-related desaturation.
Okay. Someone wanted to know, should they, how can they do exercise if it's very hard for them to maintain their weight? Because, you know, they've lost some weight and they just can't seem to gain it back. So they're concerned about how do they maintain exercising while trying to maintain their weight.
Yeah, well, exercise itself is not necessarily going to result in further weight loss. There are usually other reasons why an individual is losing weight, either because their nutritional intake is inadequate, or they have a chronic inflammatory state which causes the body to not maintain or to lose weight. In fact, increasing physical activity and exercise may shift that metabolic aspect of the body in terms of and the individual may actually be able to gain weight, and important good weight, muscle mass, rather than non-muscle weight through regular physical activity and exercise. So I would not exercise because of concerns about low weight, but at the same time as improving that healthy behavior, looking into whether or not there needs to be some nutritional supplementation or changes in the diet that go along with the increase in physical activity and exercise.
So, Dr. Hernandez, having said that, someone wanted to know if exercise is part of their daily care when they're diagnosed with pulmonary fibrosis or IPF, should they also consult a dietary person as well?
Yeah, I think if someone takes part in a pulmonary rehab program, most rehab programs would have a dietitian assess patients at least to see if and see any patient that might be at risk. But certainly, if an individual is losing weight, as per the previous question, or has a low body weight to begin with, you know, BMIs that are below normal, say below 19, for example, it would be worthwhile consulting a dietitian. Or the other extreme, if someone is overweight, or particularly if they're obese and would like to have some assistance with weight loss through dietary modification, it certainly would be worthwhile to see a dietitian to assist in that regard, to do it in a safe and healthy manner.
Okay, so Dr. Hernandez, you mentioned the HOPE IPF clinical trials about how exercise and people who are on nintedanib, how they fare as they have a better lifestyle afterwards. Is there a study on whether pulmonary rehabilitation exercise will actually prolong the life of someone with this disease?
The short answer is we don't no, is the short answer. The short answer is no. We know that it has a positive effect on things that are associated with improved survival. So participating in rehab improves exercise capacity. So 6-minute walk distance, for instance, improves. It improves, to some extent, physical activity levels. And both of those have been associated with improved prognosis in pulmonary fibrosis, but there haven't been large enough or long enough done studies that have looked at survival. So we don't know if those improvements in symptoms and exercise tolerance and quality of life and physical activity translate into a survival benefit. Because those studies haven't been done. Certainly we don't have studies that are large enough or long enough that have looked at survival as an outcome measure.
Okay. Are there any other questions people would like to ask Dr. Hernandez at this time? Well, great. I want to say thank you very much, Dr. Hernandez, for your session today. All of us have learned so much about exercise and pulmonary rehabilitation and connected with this disease, pulmonary fibrosis, and we appreciate your time. And I know that you're a busy schedule today, so thank you so much for coming on today. And for all of those who missed the session, just know that it will be able to review it probably sometime in November when we put together our whole entire schedule of presenters. And also I want to thank our sponsors, Boehringer Ingelheim Canada and Roche Canada, for supporting this platform and for allowing CPFF to bring these educational forums to you. Thank you very much, everyone. Have a great day.
Thank you. Take care.